So we start the first Saturday session, which is traditionally the news session. And we'll start this session with the first talk from Dr. Bon-Kwon Koo, who will talk about the consensus for physiologic assessment in coronary bifurcation lesions. So, of course, we have on board Goran, Stankovic, and all the people who are here, including Dr. Koo. So thank you very much for being connected to this hybrid EBC.
Thank you, Mr. Chairman. Hi, everyone. I'm BK Koo from Seoul National University Hospital.
Right.
Today, I'm going to talk about the Korean, Japanese, and European Bifurcation Club consensus for physiologic assessment. There are several imaging consensus from Bifurcation Club. Unfortunately, there's none about physiology. And that is the reason why we decided to start the project for physiologic assessment for coronary artery bifurcation disease. And the joint committee was established in 2018. And in 2019, EBC board approved this project. And we had a draft review meeting several times. And this year, February, we had a revision meeting between Korean and European Bifurcation Club members. I'm taking this chance to thank all the members from these three clubs for their time and efforts for this joint consensus documents. One interesting question is, why did it take so long for revision? Because we had already revision meeting in 21 February. It's because there has been changes in the concept and or the usefulness of physiologic assessment due to this trial. So we decided to change the philosophy of these documents from physiological assessment to physiological approach. It may be minor changes, but there is a huge changes in the philosophy or direction of this document. So this document is not to simply advocate for the more use of physiologic indices and not to show the benefit of physiological indices over imaging, but to present the true meaning of physiological approach for bifurcation lesions and to present even the limitations and pitfalls of physiological indices and also present the practical algorithm of applying for physiologic indices in daily practice. It is interesting to see that the first step in this algorithm for physiological approaches, not with the physiologic indices, but with the clinical relevance. We know that the side branch territory is highly variable, as in this figure, from 2.7% to almost 18%. And the meaning of FFR is totally different between these two vessels. So the clinical relevance is first, and that's the essential part of physiological approach. So even physiological assessment is not recommended in small vessels. And even the measured value is low, that does not always mean the benefit of revascularization. For large branches, we have to assess the procedural risk and benefit before performing the physiologic assessment. We have to admit that the pre-intervention physiologic assessment cannot predict the functional significance of side branches, and it is generally not that helpful in decision-making for one stent provisional versus upfront two-stent strategy. We stress the importance of what we want to stress is that the adequate knowledge in interpretation of the results. So if you have a lesion when angiographically significant but physiologically insignificant, you shouldn't just say, okay, this is common, this is a mismatch. But before you say that, you have to check all these possibilities, risk and benefit assessment for any physiologic assessment, especially for jailed side branches, because reported failure rate is by average around 4 to 5%. And mechanism of jailing is mainly on the ostium of the side branch. So we have to recommend the assessment of benefit and risk. And benefit is higher in short ostial lesions, and risk can be higher in heavy calcified and severe tortuous lesions. So you have to make this individual balance for all your patients before you do any physiologic assessment. And we also describe the issues over the FFR versus non-hypertrophic pressure ratio. So there can be several differences in the backgrounds and practical application and amount of evidence for bifurcation lesion. But our stance is that the greater priority is for more adoption of a guideline-endorsed physiological-based approach rather than the debate itself over which is a better index to follow the physiology indices, which is the same for the cases with reverse mismatch, angiographically insignificant but physiologically significant. Before you make a clinical decision-making with these numbers, you have to check all these possibilities and limitation pitfalls of physiologic indices before you follow that number. And we also describe the possibility and limitation of drilled pressure wire technique. So there has been several papers on the feasibility of the drilled pressure wire technique, which is the drilling the side branch pressure wire with the stent and measure the drilled side branch FFR with that pressure wire. So the procedure will be more convenient and easy and maybe safe. However, we have to understand that the pressure sensor window and gaps between the sensor and wire part is different among the branches. And there are several reports that the damage in the pressure wire and even the stent occur during the retrieval of the wire because of these different structure. So our recommendation is this technique can be feasible, but it is very important for operators to understand these different mechanical features of pressure wire and potential risk of damaging the wire itself and stents during the wire pullback. And we also describe the balance between physiology and imaging, especially for two stenting technique. We can say, and we can still use physiologic indices to define the residual ischemia and also the presence of complete functionally revascularization. However, for the procedure optimization, we recommend imaging guidance more than physiologic guidance because this is more important in patient outcome than the physiological values assessed with the physiologic indices. And we also presented the new approaches and novel technologies. We endorsed the physiologic index guided DCB treatment, which seems to be very promising. And we also strongly recommend to use a co-registration of imaging and physiology, which can review the location of physiologic significance. And for this 001 lesion, the pressure step up was quite diffuse. So you cannot relieve ischemia in these patients, only fixing the diagonal branch osteal lesion. And we also introduced the several image-based physiological assessment, their potentials and limitations, and also future direction, such as treatment planning using these non-invasive imaging physiology combined modalities. So in conclusion, ladies and gentlemen, this joint consensus documents by Korean, Japanese, and European Bifurcation Club presents the concept of physiological approach as well as the current knowledge, practical tips, pitfalls, and future directions of physiological assessment in bifurcation PCI. This document will guide interventionalists to perform appropriate physiology-based assessment and treatment decision for coronary bifurcation lesion. Final message from the document is that we should be more physiologic than physiological indices. Thank you very much for your kind attention.
Thank you very much, Dr. Koo, for this excellent summary of this paper, which I think is very important in the field of bifurcation lesion. So I will invite my co-chairman, Antonio Colombo, Sunao Nakamura, Goran Stankovic, and also the panelists. So Gerald, Werner, if you want to go to the panel or stay as you are, okay. And also Carlos Collet, Nigel, Jepson, Yutaka, Hikichi, and Fazilla, Malik, who are the panelists. So maybe, Goran, do you have a comment, question? Yes?
So this was the intention to create session as a joint hub with Korean and Japanese bifurcation clubs. And because of the COVID pandemic situation in both countries, unfortunately, we were not able to realize. The main idea of the EBC is to cooperate with other clubs. We would like to exchange on the experience, knowledge, And this was really opportunity to use this pandemic time to have some faculty members in Korea, some faculty members in Japan, and we can discuss within the group of experts what are the latest achievements. And we kept this session as a joint session with both Korean and Japanese bifurcation clubs, and we invited representatives of these clubs to present the latest news in bifurcation PCI. I really thank Professor Koo for excellent summary of the consensus. And I really would like to ask you to comment more on the balance between use of physiology and imaging that you nicely just touched upon in your presentation.
Right, so thanks for your comments and thanks for the invitation again for this EBC. So previously, physiologic documents is for physiology and to prove the benefit or superiority of physiology over imaging. So it's like an enemy between imaging and physiology. But I think that you just mentioned that we should be balanced, and we understand that both imaging and physiology are important, like as you just mentioned, that all the other clubs are as important as the EBC. So that we try to make balance so that but the missing point was that we didn't have any physiologic consensus documents among the clubs. We have 3 documents for imaging. So I think as we now have, we will have one physiology document. The next step will be that to make consensus documents for how to use imaging and physiology for bifurcation lesion to illustrate the best way to use that imaging and physiology. So that that's our next homework. So I hope that we can present some of those consensus documents for imaging and physiology next year.
Thanks. Thierry, back to you.
Yeah, thank you. Carlos, you have a comment?
Yeah, two comments concerning the consensus. So I think this is an extremely important document. I think in bifurcation PCI, before you embark in a very complex bifurcation, you really need to know that that is the lesion that is responsible for the problem. And I see that you have included the pullback evaluation that should be part of the procedure to understand whether the pressure is lost in the bifurcation, because we're going to spend quite some time and energy treating the bifurcation. So is there a clear guidance on how to assess where the pressure loss is located? And as a follow-up question to that, there is all these new devices, the microcatheters, that are very convenient to put it down in the side branch and then in the main branch. This, in my view, will facilitate the evaluation of physiology and bifurcation lesions. Is also that mentioned in the document?
So I think, Carlos, you also raised a very important question. So first thing is that you know better than I about the kind of localization of pressure gradients, for example, such as PPG indices. So the one thing I can tell is that the use of that kind of information is very important, especially for 001 lesion. So we generally think it's 001 lesion, but when we do a pullback, either with hyperemic or non-hyperemic pressure ratio, we generally find that the lesion mainly is in the main branch, not the side branch. So that's one thing. And the other thing is that as you just mentioned, that the microcatheter-based physiological assessment, we didn't describe in detail about that, and we will include that in our revision. So I promise. Thank you.
Patrick?
In the document, do you have any comment about OFR? OCT-FFR, who seems to reconcile both. I mean, and it starts to be used in some places.
Right. I think that's also a very important question. So that as shown in my presentation, we definitely include the angio-derived FFR and the CT-derived FFR and their current limitation and potential future application. We didn't include the OFR because I haven't found many papers, even for other technologies. So, but we try to stress the importance of these novel technologies, and the current limitation will be overcome and will be a kind of future strategy, so that we try to make a comment and documents open for these very important technologies.
Last short question.
Yeah, just a detail I want to expand on. There is this nice blue diagram showing the diameters of left main and polygon of confluence. And I ask you for help to understand why the polygon of confluence is shown 7 and the left main 8. And I cannot explain it to, if I do anything, if I tell people how to do bifurcations, I cannot explain why this is so small.
So I guess you just mentioned about the, the right side of my imaging and physiology for 2 stenting, so 5, 6, 7, 8. So it's imaging, so that's just for illustrating the importance of imaging. And that 5, 6, 7, 8 is derived from the Assam Medical Center data for define the risk of the future target lesion revascularization, so that it's from the clinical data, not from physiology and not from hemodynamics.
Yeah, I think we will discuss about that during the coffee break. I fully agree with your comment. So next, move to the next lecture, which is completely different, about patient-specific computational simulation of coronary artery bifurcation stenting by Yiannis Chatzizisis.
Dear Chairman, thank you for the invitation to present to EBC meeting. This is the title of my talk, Patient-Specific Computational Simulation of Coronary Artery Bifurcation Stenting. These are my disclosures. That's the outline of my talk, introduction, then validation of the computational stent platform, and then finally applications. Let's start with the introduction. This is the paper where we published the structure and the validation of the patient-specific computational simulation platform. This is the architecture of the platform. We start with non-invasive or invasive anatomical imaging. We 3D reconstruct faithfully the bifurcation. Then we assign patient-specific plaque stiffness. Then we enter all the information in the computational simulation platform, use realistic stent and balloon designs. And finally, the outcomes of the platform is fluid and solid mechanics, as well as stent morphometry. These are the applications of the platform: pre-procedural planning, stent R&D, virtual clinical trials, and education and training. A little more close up to the design of the platform. This is hybrid imaging, combining angiography and OCT or IVUS, 3D reconstruction of the bifurcation of the lumen and the wall. And then we use imaging to identify the 3D plaque constituents in the reconstructed wall. And then we assign patient-specific plaque stiffness. Here you see the co-registration of different OCT frames along the reconstructed wall, and the stiffness assigned along the reconstructed wall. Validation of our platform, we had the opportunity to perform training, first of all, of the platform in bench and clinical cases, and finally, blind testing using clinical cases. These are the bench cases. On the left, we see here with red the simulated stents, and on the right, with black, the actual bench 3D reconstructed stents by micro-CT. And you can appreciate very high agreement between simulations and reality, qualitatively and quantitatively, with an overall difference between simulation and reality around 0.03 millimeters, around 30 microns. Here we see the comparison of the simulations, which were able to reproduce fine structures like the struts around the carina, compared to reality, to the actual bench stenting, imaged with micro-CT, as shown here, and also with microscopy. And then blind testing of the simulations using clinical cases, with red, the computational simulated cases, and with black, OECD, actual clinical stents, very high agreement, qualitatively, as well as quantitatively, with an overall difference between simulation and reality in the range of 80 microns. And then finally, applications of our platform. The applications can include, first of all, pre-procedural planning, stent R&D, virtual clinical trials for regulatory approval of stents, and then finally, education and training. Starting from computational pre-procedural planning, the core idea is that we use a planned simulation-aided PCI approach, where the interventional cardiologist uploads images, angio, OCT, IVUS, etc. in the platform. Then the platform performs very patient-specific, very faithful stent simulations also uses artificial intelligence to identify the optimal stenting strategy and provide guidance to the cardiologist. We hope that with this approach, we can improve the clinical outcomes with bifurcation stenting and, of course, reduce the costs for the health system. Here's an example of the simulation-aided approach. A 60-year-old woman with significant distal left main disease identified by angiography and IVUS. We entered this information in the platform to 3D reconstruct faithfully the diseased left main bifurcation. You can appreciate here the flow acceleration across the diseased distal left main. We applied patient-specific plaque stiffness in the diseased bifurcation coming from IVUS. And then we entered this information in the platform to perform computational stent simulation using realistic stents and balloons, identify the optimal pre-dilatation technique, the optimal stenting technique, the position of the stent, the size of the stent, and then the optimal post-dilatation approach. And then with this in mind, we went back into the clinical setting and having the plan simulation approach as a guide, we executed the same steps very faithfully from pre-dilatation to left main stenting to post-dilatation. And here is the pre-procedure angiography and the post-computationally planned procedure angiography. Very good result. Also confirmed by intravascular ultrasound before and after the left main PCI. Stent R&D, another great application of the computational stenting platform. We know very well that simulations play an important role throughout the total product life cycle, from conception of device to regulatory approval and post-market monitoring. And with this in mind, we had the opportunity to test the Megatron stent design performance in using our computational stent simulation platform. We used different designs, the Synergy 10 peak, Megatron 9, 10, and 12 peak. We tested those designs in patient-specific left main bifurcations using realistic material properties, and we found that the Megatron 12 peak exhibited better performance compared to the other prototypes and to Synergy in terms of expansion, scaffolding, radial strength, and tissue prolapse. Another application, virtual clinical trials, very interesting perspective. We can use simulations, computational simulations, to compare different devices or techniques using not real patients, but real patient data, and using simulation outcomes which are highly predictive of the actual clinical outcomes. With this approach, we can identify, filter down the best devices and techniques, and then perform a very focused clinical trial approach with real patients and actual clinical outcomes. With this visual clinical trial pathway, you can inform industry, FDA, universities about the optimal device and technique performance. We can acquire scientifically impactful knowledge in a very time and cost-effective way. Of course, the foundation of this visual trial approach is the so-called big data, and we are in the process with an initiative through the Sky Bifurcation Club and ABC to create this big bifurcation atlas. And then finally, computational sense simulations can be used for education and training. We use the simulations to educate our trainees, staff, even patients on the different nuances and steps of different techniques. Here you see provisional, tap, clot, decay, crash. And of course, we use extended reality to fly through and see all the techniques, all the steps from the inside, helping our trainees to learn more, faster, and better. With that, I would like to thank our funding sources, federal funding sources, industry and philanthropy, and of course, a big thank to my group, world-class engineers, MDs, and vascular biologists who are behind all these amazing evolutions in the computational stent simulations world. I would like to thank you for your attention, and now it's open to questions.
Thank you very much, Yiannis. You are here at EBC in Brussels, so it's very nice to see you. And I think we were dreaming about that many years ago, but now we are really in this new field. So it's very nice. Any question, comments to Yiannis? Yes, Gerald.
Really sounds fantastic, but there is a human factor in it. How to bring the precision of your bench into the lab so that the predicted position of the stents is really achieved. So you need some co-registration, you need to rely on not slipping the position.
Dr. Chatzizisis, yes.
Yeah. So thank you. That's a very, very correct point. our initial agony was how we can reproduce the reality. Now the next step is how we can reproduce the simulations in the cath lab. It's a field that is evolving. Definitely the human factor is here. Absolutely, there's no discussion about this. And we rely on the human factor. But definitely having a guidance, going in a dark room with a torch, and the torch is a simulation here, or any kind of planning, is definitely helping the proceduralist to achieve the best possible result. I believe without this guidance, things will be even more stressful, even more complicated. So we just try to take some anxiety, take a layer of complexity out of the equation, but still, we deal with human beings. We are human beings, and the biological variability is, infinite.
Yeah, we recently we learned from Jean Fajadet that he learned by making mistakes, and with this kind of simulation, you can make mistakes, and we learn a lot by doing that. So I think it's really great. Any comments? Yes, go on.
Thank you very much, Thierry. I would like to congratulate Yiannis on excellent presentation and very inspiring. And I wish to ask him if he can provide some technical specificities on that big registry data that he's planning. Maybe this is a good place with all these bifurcation enthusiasts to bring as a conclusion from here a cooperative project and how can we participate individually in your registry. And second, I would like to ask Professor Hikichi to comment as also one of the long-lasting friends of the EBC and really expert in bench and simulation.
Yeah, well, so thank you, Goran. To your point about the registry, I think, we should be simple in what we want to achieve success. So essentially, we'll look for any kind of anatomical input. Angiography only, ideally angiography plus IVUS, ideally both branches, but at least one branch is fine. Angiography and OCT, even non-invasive imaging, anatomical imaging with CT. So it's very versatile. We're not so dependent on the type of data, but we're definitely dependent on the volume of data. So any kind of anatomical input, invasive or non-invasive, is very useful for the platform. It can be very versatile. And now to Hikichi about the point for the flow.
Oh, thank you very much. It's a great, congratulations. It's a great technique. I hope that if this method is established, it will be possible to conduct a comparative study without using a human. However, the PCI, we have to use the human technique yet. So it is very important. So I believe the bench study, such I always do technique, is yet important.
Okay, thank you very much. So I think it's time to move to the next lecture. We are always learning from Dr. Kassab. Every year he's bringing something new. So this time it's a study of coronary atherosclerosis using blood residence time.
I would like to thank the organizers for the kind invitation. I'm happy to present on the study of coronary atherosclerosis using blood residence times. Javad, the first author, is my fellow, and this was in collaboration with Bifurcation and Yiannis. So coronary artery disease, as you all know, is the leading cause of death in the US, with over 800,000 deaths annually. Certainly, stent placement is performed in up to 90% of the cases in the over 1 million percutaneous coronary interventions in the US. The stent coronary bifurcations are about 20% of all cases. About 15 to 20% of the stented coronary bifurcations fail between 6 to 1 year post-intervention. This remains to be high relative to stenting straight segments. Now, restenosis depends on various physical and biochemical factors, including blood residence time, where high residence times provide greater time for both inflammatory cells, cholesterol, and other biological species to engage the vessel wall. The objective of this presentation is to calculate blood residence time in atherosclerosis, atherosclerotic patient vessels using residence time method, abbreviated as RT. We also plan to compare the RT with relative residence time, which is the more conventional method. We also intend to visualize the flow pattern and zones with high risk of atherosclerosis using the proposed resident time method. The approach consists of taking patient-specific coronary angiograms, doing segmentations to reduce the 3D geometry, including 3D reconstruction. We create meshes from those geometries, and then we utilize computational fluid dynamics to compute the parameters of interest. 3 subjects were considered. 1 subject was normal with fractional flow reserve greater than 0.96, so no stenosis. 1 patient had a functionally significant stenosis with FFR less than 0.66. And then 1 additional patient C, we considered both the LAD first diagonal coronary bifurcation before and after stenting. The resident time method has been introduced and elaborated on previously by our group. We essentially use an advection diffusion equation as stated by equation 1. C is the concentration and U is the velocity of the flow. And then from that, a scalar blood resident time is defined as the integral as per ratio of integrals as per equation 2. And then if you combine equations 1 and 2, we come up with the field equation that allows us to solve for the scalar blood resident time defined as A here. This shows some color schematics of the various simulations. The average resident time for patient A was 0.08 seconds, the units are in seconds, and for B was just only slightly smaller than that. The average resident time for the main branch decreased by 6%, but increased by 13% for side branch after stent placement in the bifurcation segment. And again, you see here a color contour that shows the distribution of residence time from blue to red, from low to high. Now, we also computed the path lines, the resident path lines, and you can see how they differ for the various subjects. For patient A, the flow was not recirculated or separated. That's in a normal subject, and the streams didn't appear into the lumen. For patient B, recirculation was not significant in systolic phase. However, in diastolic phase, flow was recirculated after the throat of the stenosis. And finally, in patient C, the flow after separation branches had tendency to increase along the inner wall of bifurcation. And then the flow around the outer walls of the bifurcation was relatively low. Now, we also, as a comparator, we contrasted our results with those of the relative residence time, and you can see the results here. The relative residence time and residence time contours appear show predilection for stenosis and restenosis zones similarly. The average RT and relative RT for patient C with stent to compare without stent in cardiac cycle increased 30 and 27% respectively. For the normal patient, A RT and relative RT average on cardiac cycle were relatively similar, 0.25 and 0.19. You can see the relative resonant time. The units there are the sort of inverse of pressure or inverse of Pascal, whereas resonance time is given directly in a time scale or seconds, which is physically easier to understand and interpret. So for patient B, resonance time and relative resonant time average for cardiac cycle were 0.149 and 0.16. We also considered the wall shear stress. The wall shear stress increased abruptly at the throat of stenosis and separated at bifurcation. Wall shear stress decreased substantially when there is separation of flow and recirculation, as is well known. And finally, low wall shear stress and high resonance time regions are, of course, where atherosclerosis or restenosis tend to favor. We also considered a parameter called localized normalized helicity LNH, and it was used essentially to visualize orientation of velocity and the vorticity vectors. The ISO services can detect which stenosis and stent struts may affect flow pattern and cause flow tortuosity. The relative resonant path line showed recirculation and helical flow where the LNH ISO surfaces appeared, so they correlated, and hence we see a relationship between the two. So finally, in conclusion, the resident time and relative resident time are both clinically relevant and can both determine region with high risk of atherosclerosis or restenosis. The relative resident time method allows visualization of flow pattern and lumen for diagnosis of coronary artery disease in early stage, of course, ideally before stenosis initiation and restenosis progression. And finally, the residence time method can be applied for calculating RT for both blood cells and proteins, because again, that determines the amount of time that cells have near the wall and hence can transport to create potential dysfunction, remodeling at the wall, and atherogenesis. Thank you very much. Bye-bye.
Thank you very much, Ghassan. Do we have comments in the room? Yeah, I was sure that Patrick had some comments.
No, I think it's very interesting. The question that I have is that residence times applicable for compound in solution in blood, let's take LDL cholesterol, LPA, etc., or also applicable to corpuscle, I mean monocyte. Is there a difference? Because in the initial equation it was based on diffusion, but diffusion of something in the range of nanomere or something like a monocyte in micron. Is there a difference there?
So maybe Yiannis, you can answer to this question.
Thank you, Patrick. It's midnight in California, so now I have the burden to answer this difficult physics question. I think Nicholas might want to take over here.
Full circle. No, I think you're right. I mean, there is an impact of different element on residence time. So I think you're right.
I want to claim that I have understood 10% of what was presented, but I can make it even more complex because I think your formula is on steady flow and not on pulsatile flow conditions. And because I didn't see pressure and pressure integration. And that might be important, especially in a bifurcational lesion.
Yeah, so this is pulsatile flow.
Is it?
It's fully pulsatile, systole,
Okay.
diastole.
Because
Yes,
shouldn't there be some pressure?
we show snapshots from systole and diastole. That's what you see. So those 4 snapshots at the end represent the whole cardiac cycle. It's systole, diastole,
Okay.
non-Newtonian pulsatile.
Video showing the change in color will be beautiful.
Yes,
Yeah?
yes,
From blue
yes,
to
yes,
yellow, red,
yes,
and so
yes. You're right.
And you know, there is always a simulation and the reality. So you never know what the reality is.
No, but I think what is interesting is that it's pointing out that if you have too much enlargement of the vessel at the wrong place, you have a higher residence time. And then you promote atherosclerosis. So it's intuitively, it's the opposite. You think that bigger is better, but bigger maybe promote atherosclerosis at a longer time. So I think it's very interesting. So respecting the natural anatomy of the bifurcation, I think is very important for the future, for the patient.
Thierry, you're right. So smaller is definitely not better. Big is not better. Physiologic is better.
Absolutely.
And respecting the laws of physics, the geometry, and the tapering of the vessel, that's what we should be doing by, with our interventions.
This is the philosophy of the EBC since a long time. Respect the fractal law. I think it's very important. So let's move to the next lecture, which will be also very interesting by Dr. Kang, the impact of clinical and lesion features on clinical outcomes after bifurcation PCI. So it's insight from Bifurcation registry.
Hello, everybody. My name is Jeehon Kang, and I'm from Seoul National University Hospital. It's a great honor to speak at the EBC 2021. It would be much more better if we could meet in person, but I will do my best to give my message on Zoom. The title of my speech is The Impact of Clinical and Lesion Features on Clinical Outcomes After Bifurcation PCI. This was an analysis that was done on the Bifurcate registry that I will explain during my speech. I have nothing to disclose. Now, regarding bifurcation PCI, there has been an increase in the bifurcation PCI, especially for left main PCI. And along with this increase in bifurcation PCI, there has been an improve in clinical outcomes. This is probably due to the improve of PCI techniques, the improvement of devices, optimal patient selection, and sophisticated medical treatment for the bifurcation PCI patients. However, despite this advance, bifurcation PCI is still associated with a lower procedural success rate and worse clinical outcomes compared to simple PCI. Regarding the optimal treatment strategy for bifurcation PCI, there has been a couple of scoring systems or criterias. First is the resolve score, which was studied to evaluate the risk of side branch occlusion. And second was the definition score, which was a systematic criteria which could guide the optimal stenting strategy. However, we could see that all the factors that were included in these criteria or scores were angiographic or lesion-related factors. However, we all know that it's not difficult to appreciate the fact that clinical factors is very important in determining the clinical outcomes in the patients that we treat. So especially in bifurcation PCI, we have a feeling, we know that both clinical and lesion factors are important, but how can we integrate these two factors? To do an analysis on this topic, I used the Bifurcation Registry, which is the largest bifurcation dedicated real-world registry. The abbreviation is the Noble Insights from the United RAIN and COBIS Bifurcation Registries. And this was a retrospective multi-center, multinational observational registry, which included 5,500 patients whom were treated with second-generation DES for bifurcation PCI. Just to give you a slight overview of the importance of a registry is that although the clinical evidence that we use in medicine is usually derived from RCTs, previous RTCs regarding bifurcation lesions have not given a concrete answer, but rather gave a aggravated confusion even for the simplest question, which is, should I use 1 stenting or 2 stenting for bifurcation lesions? The Excel, the Noble, the DK Crush studies all studied the same topic. However, the results were very different regarding this very simple question. So probably the real world registries, which has practical strong points compared to RCTs, may be a better registry, a study topic for the bifurcation PCI patients. So based on the bifurcation registry, we could see that based on the 5,500 patients, the mean age was 66 years old, hypertension was in 66%, DM was in 33%, CKD was in 13%, and the LV ejection fraction was about 58. Regarding the location of bifurcations, we could see that around 30% there were left main bifurcation lesions, and 65% were true bifurcation lesions. For the 2-year clinical follow-up, the all-cause death rate was 4%, MI was 2.4%, and also regarding the composite endpoint, MACE occurred in 9%, and the hard outcomes, which we defined as death and MI, recurred in 5.4%, whereas the lesion-oriented clinical outcomes, which we defined as target vessel revascularization and target vessel MI, occurred in 3%. So for the feature selection of adverse clinical endpoints for MACE, we used the lasso regression model, from which we could select 9 features, 5 which are clinical and 4 which were lesion features. For abbreviation, we could see that old age, heart failure, renal disease, current smoking, and diabetes were clinical features. And for angiographic features, the left main disease, presence of paroxysmal lesion, and presence of a side branch lesion, and the small main branch were angiographic features for MACE. So we integrated these 9 features into a single score, so-called the bifurcation score. And regarding the weight, these weights were calculated from the Cox regression model. We could see that the distribution of the bifurcation score was as follows. And compared to the lesion clinical features, the bifurcation score had an improved predictive value for MACE. However, going one step forward, we studied the distinctive predictive value for other outcomes, such as the hard endpoints and the lesion-oriented composite endpoints. Interestingly, for the hard endpoints, we could see that by the increase in the number of clinical features or lesion features, that there was a more superior increase in hard endpoints for clinical features compared to the blunt increase in lesion features. From this, we could see that for hard endpoints, the clinical features were more important. However, for lesion-oriented composite endpoints, we could see that the slope was steeper for lesion features compared to clinical features. Therefore, we could say that the importance of lesion features were more important in lesion-oriented composite endpoints. Also, we divided the population into 4 subgroups regarding to the high and low lesion risk and high and low clinical risk. And we could see that patients with a high clinical risk and low lesion risk had a higher event rate of hard endpoints compared to those with a high lesion risk and low clinical risk. This shows the importance of the clinical risk in hard endpoints. Also, for lesion-oriented composite endpoints, we could see that the event rate was much more higher in those with a high lesion risk compared to those with a high clinical risk, again, stressing the importance of lesion risk in lesion composite endpoints. So this is the conclusion of my speech. From a very large bifurcation dedicated registry, the Bifurcate registry, we could select 9 features, 5 clinical and 4 lesion features that were important in predicting clinical events. These 9 features were integrated into a single score, the Bifurcate score, which is very easy to calculate in the clinic. And interestingly, the clinical features were important for hard endpoints, while the lesion features were important for lesion endpoints. This is a quite obvious statement, but again, from this statement, we can stress that considering both clinical and lesion features are important in treating bifurcation PCI patients. Thank you for your attention.
Thank you very much. Thank you very much, Dr. Kang. I think it's fascinating to see how the characteristics of the lesion influence the outcome of the patient, even more than the risk factors. So I think it's very interesting. Any comments? Yes, Jens.
Yes, congratulations for a very, very clear talk and use of a huge data set in prediction. This seems to be the first step for personalized medicine, because we have to evaluate the clinical status of an individual and the technical issues from a population. I don't know if we have direct contact at the moment. So I would just like the comment on that. Thank you.
Oh, thank you for your comment. I can see that the previous talks were more micro. They were focusing on very, very small, important factors, but my speech was quite a lot based on a large registry. So I can find that the focus was different. But again, thank you for your comment.
I like very much the concept of highlighting the relationship between the impact of clinical or angiographic characteristics or procedural characteristics on different clinical endpoints. This is important in my mind, the fact that we may have some endpoints that are more influenced by the clinical features and some other endpoints that are more influenced by the technical characteristics that the operators is facing, and this is important for future trials design. When you have different populations, there is the possibility that the baseline characteristics influences the impact of a specific baseline factor in determining the outcome in this population. I mean, if you have a population without calcifications, you will, or with low calcification in the lesions, you will have less impact for calcification in the outcome. So how you compare the prediction model you did with other prediction models in bifurcations, like, for example, the Chinese definition criteria?
Yes, thank you for your comment. Again, the external validation issue is a very important issue that we have to solve in the future. But I think that this is one of the beauties of a very large-scale registries, because as far as I know, this is the largest registry. So I agree that registries with different characteristics can have different impact for a single factor. But if you get a large registry, or if you get a population-based registry, then all of those factors are inside the registry. So I think that the factors that are important in our trial may be similar in other trials, but again, external validation with other registries is very important. Regarding the definition score, the definition study, that study also only included lesion characteristics. So they sort of left out the important clinical factors that we found in our study. So I think that a direct comparison might be slightly difficult between these two scores or studies or criteria.
Professor Fazilla Malik has a comment. Fazilla, please.
Congratulations. That was a fascinating talk. I was just wondering, so one of the clinical criteria was heart failure. So did you consider taking LV ejection fraction as one of your parameters? I mean, it's not clinical, it's an investigating feature, but do you think that would impact your results? Instead of the clinical, the broad term was heart failure. So instead of using heart failure, could we have used ejection fraction there?
Well, actually, the definition of heart failure was a LV ejection fraction lesser than 40% or a clinical history of heart failure. So I think it's a
right. Okay.
Concept.
Thank you.
Okay. Sunao, you have a comment.
Okay. Short question. So actually, which kind of the lesion element is most important? So actually, if currently, anyway, more than 10 years ago, I supported the EBC group And then I'm a strong believer of the provisional stenting the best way. But currently, if you look at the definition 2 trial and also the COBIS III registry data, the big size of the bifurcation region, we have a space to do the bifurcation and the 2 stenting technique. So just, I guess, element, the small size vessel, is one of the, the worst, the lesion-oriented composite endpoint.
Yes, well, actually, the most important lesion factor was the presence of a left main lesion. And the second was the presence of a proximal main branch lesion. So actually, the important factors were related to the bigger vessels. So I think that it is true that the small vessels doing multiple stenting in smaller vessels may be a risk factor for any kind of lesion side effects, but actually in our study, doing any kind of procedure in a larger vessel was associated with a higher risk of lesion composite outcomes.
Thank you very much. Very interesting.
Thank you very much. So let's move to the next lectures. I think we have talked about 2 levels of comprehension of the outcome of the patient, but now we need to add a 3rd level, which is a technique that is used. So the first lecture will be by Dr. Gwon, the 10 years trends in bifurcation PCI, lessons from COBIS II and III.
Thank you for the introduction. I have nothing to disclose related to this presentation. Few data are available on temporal trends in the procedure and clinical outcomes of bifurcation PCI, which may help us understand the clinical impact of new techniques and devices in this field. We tried to evaluate the 10-year trends of bifurcation PCI and their prognostic effects in large nationwide real-world registries, which is COBIS II and COBIS III, covering the period of year 2004 to 2015. The inclusion criteria of the studies are the same. The coronary bifurcation lesion with the side bench equal to more than 2.3 millimeter in diameter confirmed by Collet PCA, and also all lesions should be treated with the DES. The exclusion criteria of the study is somewhat different. So we excluded 45 patients with LV ejection fraction less than 30% from COBIS II registry to match the patient selection criteria. The final study population was composed of 5,498 patients. So this is clinical and lesion characteristics according to the 3 trimesters divided by period. The proportion of diabetes has been increased, and also the proportion of chronic kidney disease has been increased over time. And the multivessel disease proportion was significantly increased also, and left main bifurcation is more widely included in the later trimester. So more complex patients have been treated with PCI over time. When you look at this figure, you can find that the multivessel disease proportion is higher. Diabetes, the proportion is increased over 10 years. And also the true bifurcation lesion proportion was increased significantly, but the left main bifurcation is less likely to be included in the later period of the registry. So this is suggest that we have the better target lesion selection, avoiding left main true bifurcation lesion, which may be not the excellent target for PCI procedure. This is the procedural characteristics. As you can see here, the proportion of the one-stent technique has been increased significantly over time. And second generation TS is actually has been available since the year 2009 in Korea. So after this period, virtually the second generation DS replaced all the DS used before. Transradial intervention has been grown over time, and the use of IVUS, the application of the proximal optimization technique also has been increased, mostly after second trimester. The procedure success in main vessel has been somewhat increased, but notably the success rate in the side branch has been reduced significantly, mostly because of residual percent diameter stenosis, which has been increased over time. Maybe this is because of the wider application of one stent strategy rather than two stent technique, which is related to the higher residual stenosis after the procedure. So, as you can see here, after this period, the simple crossover technique is dominant. When the one stent with a side wedge ballooning, the stent technique has been decreased somewhat. So, what about the clinical outcomes at 2 years? The clinical outcomes has been improved dramatically, both device-related adverse event, so-called target vessel failure, and also the patient-related adverse event has been improved dramatically. Notably, after the year 2010, this actually matched the period of full availability of generation DS. Now, second generation DS may be the major cause of the improved outcome. The improved clinical outcome is mostly driven by the target lesion revascularization, which has been reduced dramatically. The rate of cardiac death, MI, or stent thrombosis has not been much improved, and not significant. This is actually virtually the same over a period. The improvement of clinical outcome has been noted in both the two-stent strategy and one stent strategy, but more notably, dramatically shown in second stenting strategy. Also, the one stent technique has a significant improvement, but in two-stent strategy, the outcome, the target vessel failure was halved with 50% after introduction of a second generation. The what other predictors drive the changes in the prognosis? In the multiphase, we tested many predictors and found that the only two variables have a significant interaction p-value: second generation DES and true bifurcation lesion. You can see clearly the second generation DES is a major impact of improved target vessel failure, and also the true bifurcation lesion, the outcome was dramatically improved after introduction of second generation DES, but one stent technique, actually, the change was not so dramatic, not significant. How about the PCI optimization technique? Actually, we have the wider application of image guidance and path technique and fine kissing ballooning. Interestingly, those techniques, imaging guidance, fine kissing ballooning, proximal optimization technique, was associated with the better clinical outcome in terms of target vessel failure only in two-stent strategy. In one-stent strategy, those techniques did not improve the clinical outcome. So optimization technique is more important in the procedure, the complex procedures such as two-stent technique strategy. This is a summary and conclusion. In the coronary bifurcation PCI from year 2004 to 2015 in Korea, we have noticed that the more severe patients, more severe lesions were included in this registry. But with the help of a simple wide application of simple strategy and better device such as second generation DS and better optimization technique like IVUS, fine kissing ballooning, and the proximal optimization technique, we have achieved better clinical outcomes, particularly in patients with a true bifurcation and treated with two-stent strategy. Thank you for your attention.
Thank you very much, Dr. Gwon. We're always learning from the COBIS registries, and the paper is open for discussion. I'm sure that there will be some questions or comments. Yeah, Manuel. I will try while the microphone is coming. The first question to me is about POT. We can see that the role of POT, you're the same, sorry. We have seen that POT in the last period is about 25% of cases, which are very low. And it's difficult to conclude that POT is not useful in provisional, while it is in two-stent technique. I think it's in both groups, POT is very useful. So how to understand that POT is used in only 1/4 of the patients in Korea, why it was introduced by Olivier Darmon in 2007?
Thank you for the question. And first of all, I'd like to apologize for the poor quality of the recording. I didn't know that. Sorry for that. Actually, the POT technique, I think this is the most important technique for both one-stent and two-stent strategy. But actually, it has been not widespread in Korea because I'm not sure the learning education program is not so active in Korea until that time. So after the start of the Bifurcation Club, we try to propagate all the techniques, and still many people think that even in the vessels with the largest discrepancy, proximal to distal main size in the main vessel, that they are happy with just the crossover stent. So we need to have a chance to have an education program for the people. So,
Manuel?
I have the same comment, but you know, if the recent inclusion in COVID registry receive a higher proportion of POT or not?
So actually, I don't know exact numbers, but in our registry, in recent registry, the final kissing ballooning was used in the more than 30%. And the POT is almost 27 and 30%. So if we finalize with final kissing ballooning, so the POT technique is many people don't use a POT technique. I'm not sure about that actually. So in COBIS II registry, we found that if you finish with final kissing ballooning, there is no benefit of a POT, and it is published for the COBIS II. Because the final kissing ballooning also have a role to expand the more in the proximal portion of the main vessel, just like the POT technique. So still we don't know. POT should be beneficial in addition to final kissing ballooning. So future study is needed, I think.
Malik?
Maybe one more question. Congratulations. So you have thousands of patients. Did you check the importance or impact of the fact whether the patients was treated in high volume center or just in standard institution? Did you find or did you see any differences?
Actually, we have analyzed that, but it's very confused. There's a lot of confusion about this. Some high volume centers are associated with the higher rate of restenosis and event. Maybe restenosis is associated with the higher follow-up in angiography follow-up rate. So I don't remember the correct exact analysis in the COBIS III registry, but in the experience of COBIS II analysis, I think that doesn't matter actually. So high volume center was not necessarily associated with a better outcome.
Dr. Collet?
Yeah, I have a question concerning the predictors of outcomes. You mentioned that the new DS was the major independent predictor of outcomes, but you have also very good proportion of patients with imaging guided. Did you find some signal that imaging was associated with better outcomes?
The opposite.
Maybe I believe the imaging is very important for, especially for a complex anatomy and complex procedure, but it is the registry. So maybe some operators use more images and some physiologic study. They are more have more knowledge about the bifurcation. So it is too early to determine that imaging. The adoption of imaging technology is associated with a better outcome. I believe so, but I think this is not yet proven in our registry. I think it should be the proof in the future random trial. As far as I know, the IVUS is associated with better outcome in CTO, long lesion, and the RCT proves only in 2 lesions is a trisomal. So in bifurcation, we should prove that the imaging modalities improves outcomes in the random trial. Maybe Dr. Koo will do the study, right?
Okay. So actually in COBIS II in analysis, IVUS usage was prognostic indicator in only in 2 stenting, so that there was no benefit in 1 stenting, and I think it makes sense. But as you just mentioned, that the IVUS usage is around 40%, and it depends on who used it and how it was used. So we need further data for that as well.
Goran, you want to comment?
Yes, just a brief comment. Recently, Werner Chevalier published in Eurointervention EU master data, similar size of the registry with 4,500 patients, and almost replicated your findings, confirming something that we have to openly say today. 1/3 of the patients has proximal optimization technique performed, less than 1/3 has kissing balloon inflation. And if there is no any difference in the analysis that those optimization techniques actually impact on clinical outcome, this is the reality that I think should be one of the important messages, and we should pass that message to community, because 1/3 of the patient has something that impacts on MI and that, and I believe it's a really strong message coming from 2 largest registries so far.
Thank you very much. So we can move to the next lecture by Patrick, which will be about the syntaxis 10 years, looking at the bifurcation subgroup.
Predicted and observed mortality at 10 years in patients with bifurcation lesion in the syntax trial. This is a predefined sub-analysis. The present study is a predefined subgroup analysis of the syntax study, which was a investigational driven extended 10 years follow-up of the syntax trial. For the purpose of the present analysis, patients were categorized in 4 groups: PCI with at least 1 bifurcation on the diagnostic angiogram, PCI without bifurcation, CABG group with at least 1 bifurcation on the diagnostic angiogram, and CABG group without bifurcation. Of course, the baseline characteristics are different. Patients with bifurcation are 2.5 years older than without bifurcation, and their Euro score is higher, 3.9 versus 3.4. The ratio 3 vessel disease left main are different, with more isolated left main with 1 vessel disease in patient without bifurcation versus more patient with 3 vessel disease in patient with bifurcation. The syntax score is higher by 10 points. Low syntax score is prevalent in the group without bifurcation, and the high syntax score is more prevalent with bifurcation. The number of stent and the total stent length is higher with bifurcation, whereas in surgery, off-pump was more frequent in patients without bifurcation. Where are these bifurcations located? In the distal left main in 27% and 6% of the ostial and left main shaft has also at least one bifurcation in the distal bed of the three-vessel disease. In patients with three-vessel disease, 33% has one bifurcation, 26% two bifurcation, and 8% three of more than three bifurcation. Death, stroke, or MI at 5 years, patients with bifurcation are depicted by a solid line and patients without bifurcation by a dashed line. The worst outcome is in patients with bifurcation, 21.9%. The Kaplan-Meier curve of CABG with and without bifurcation are superimposed with a rate of 17.2%, and the best outcome is for CABG without bifurcation with a rate of 13%. As far as revascularization at 5 years is concerned, the worst rate is 26.7% for PCI with bifurcation. This rate is significantly different from the 19.4%, which is the rate without bifurcation, and the rate of revascularization of CABG with or without bifurcation are 14.6% and 11.5% respectively, and are not significantly different from each other according to a log rank. The next slide shows the hazard ratios for clinical outcome, CABG versus PCI in patients with three-vessel disease and bifurcation, and in patients with left main and bifurcation. All the hazard ratio are adjusted considering the numerous confounding factor in the baseline characteristic. In three-vessel disease, all the hazard ratios are in favor of surgery. Death, stroke, MI at 5 years, 0.72, revascularization at 5 years, 0.38, death at 5 and 10 years, 0.65 and 0.61. 28.8% of death in PCI versus 19.7% with CABG. In distal left main, there was only a difference in revascularization at 5 years and no difference in all-cause mortality at 10 years, 31% for surgery and 29.1% for PCI. The next slide shows all-cause death at 10 years, bifurcation in red versus non-bifurcation in blue. Surprise, surprise, the winner with the lowest mortality, 19.8%, is the PCI group without bifurcation. The worst outcome, the solid red line with a mortality of 30.1%, is for the PCI group with at least one bifurcation, which is significantly very different from the PCI group without bifurcation that had a mortality of 19.8%. Then we have the two CABG group, the one with bifurcation, the one without bifurcation. Both have an identical rate of mortality of 23%. That makes sense. Graft bypass that type of bifurcated lesion. Now, the key question, based on the average treatment effect, should you send all your patients with bifurcation to surgery? The answer is, of course, not. Today, we have decision tool to move from average treatment effect to individualized prognosis. In the randomized population of a trial, there are individuals in green who expect to derive benefit from the novel treatment, others in blue who have an equivocal response, and those in red who will be harmed. by the novel treatment. In clinical trial, the average treatment effect result in a kind of multicolor patient, which expressed the mixed average effect of the different treatment response of each individual in the trial. It is nowadays essential to identify this individual with an heterogeneous response and segregate the patient population based on treatment response. The syntax score 2020 was redeveloped to predict 5 and 10 years mortality and 5 years MACE in the Syntaxis trial and was externally validated in the Freedom, BEST, Pre-Combat, and Excel trials. There are 2 effect modifiers, the anatomical syntax score and the type of disease, 3 vessel disease and left main, and 7 prognostic factors, age, diabetes, creatinine clearance, ejection fraction, current smoker, peripheral vascular disease, and chronic obstructive pulmonary disease. The probability of 10 years mortality can be calculated with the formula at the bottom of the slide. If you intend to treat the patient with CABG, use the formula with the blue parameters related to CABG. If you intend to treat the patient with PCI, you use the formula with the red parameter related to PCI. This slide deals with the individual predicted mortality versus the observed mortality at 10 years in patients with bifurcation. The parameter of the syntax score 2020 are tabulated for case 1 and case 2. For case 1, there is an absolute risk difference in mortality at 10 years of 2.1%, 7.8 for PCI, and 5.6 for CABG, very acceptable. There is in case 1, quasi-équipoise of PCI and CABG for all-cause mortality, and you will, of course, select PCI. In case 2, the difference in mortality is 12.9% in favor of CABG. CABG is better. PCI is not acceptable. The $1,000 question is, how many cases with équipoise or PCI better than CABG are there in the bifurcation group and are to be identified? The difference in mortality at an individual level is considered as a treatment benefit in survival of CABG over PCI, of vice versa, of PCI over CABG. All the predicted and observed treatment benefit have been regrouped in 4 quartiles. In the first quartile in green, the predicted treatment benefit is in favor of PCI, and indeed the observed death difference is in favor of PCI as depicted by the Kaplan-Meier curves in the first quartile with a higher mortality after CABG in blue. In the second quartile, there is a perfect équipoise in mortality with Kaplan-Meier curves superimposed. In the third and fourth quartile, the predicted and observed treatment benefit is in favor of CABG, and the Kaplan-Meier curve shows a significant higher mortality after PCI. The good news is that 50% of the patient with bifurcation may nevertheless be treated with PCI according to the prediction of the syntax score 2020. In conclusion, presence of bifurcation lesion is a warning signal in the decision-making process of the heart team, since PCI in this subset of patients was associated with a significantly higher all-cause death at 10 years compared to PCI. However, this overall bad prognosis could be possibly mitigated and even overruled by the individual probabilistic analysis provided by the syntax score 2020. Thank you very much.
Thank you very much, Patrick, for this very important data sharing with EBC. I think Gerald has a comment.
Very solid data and unique because we don't have any other trial and not in the coming. But there are two questions I have still with the syntax analysis. The distal bifurcation in the left main was critical, and it was the taxus stent. And don't we think that this impacted the outcome of syntax regarding these bifurcations? That is the first question. The second is the anatomical syntax score is still in the prediction rule as an important factor. And there is one, unconfounded factor in the syntax score calculation that is giving CTOs the factor 5. That was just, you didn't have anything. It was difficult in 2005, and it was rightly so because the success rate was low. But that has changed completely as in syntax 2 was shown. So shouldn't this be considered in recalculating or assigning a syntax score?
I think that there are two excellent questions. And of course, the advantage of long-term follow-up is important, but that's somewhat misled by the new treatment, the new possibility of treatment. So what we have done to respond this question, which is a classical question of the reviewer, is that we went to the Credo Kyoto registry of Takeshi Kimura, and that has been published recently in JACC. And in the cohort 3, you have the second generation of stent, that's point number 1, and point number 2, 67% of imaging after procedure. And what was interesting is that you're right, there is some shift in the absolute risk difference in mortality that you can accept. There is now 4.5% march. And I think that 4.5% upgrade in the absolute risk difference come from the new stent, come from the imaging, and probably also from the treatment of CTO. I think that's very important. Now, every time we adjust that, I mean, the people should not be tired of the syntax score 2, which was the Lancet 2013. This is the 2020. I'm afraid that I have to tell you that there's more coming because we are applying now machine learning to the statistic and including many more factors. You know, Ranucci, you remember Ranucci had age, creatine clearance, and ejection fraction. That's what we call a parsimonious score. But today, the world is changing. You can put the whole database, and that's what we have done. So you will see very soon even more information. And I must be, I'm impressed by the fact that you can more and more predict on an individual basis. And I think that it's interesting, you don't have to be in a trial. If in your hospital you organize the database, the collection of the data, if you put, for instance, the hemoglobin A1C in the type of measurement that you do systematically in your hospital, you have to connect your hospital with the machine learning, and you will be able to predict things much better. I think that's going to come in the next decade.
If you had a comment or question?
Yeah, my first comment was about the stent that was used for syntax and the progress we have made. That has been shown also in the registry of COBIS. And do you think that will lead to a new comparison versus surgery versus PCI for left main distal bifurcation lesions?
Yeah, the left main is already very good. I mean, basically, we have by 2% a better all-cause mortality than the surgeon. So there's nothing, it's already excellent. The real thing is the three-vessel disease. You know, the three-vessel disease is, we are not yet there. I mean, even with the new technology, we are not yet there. And, you know, we do this trial of bypass surgery without cine angiography, multi-slide CT scan. When I see the patient that the surgeon are treating, it's really beyond our capacity. Yeah, I mean, you have a super expert in CTO here, but when you have two CTO and collateral and things, it is beyond. I mean, all these cases made by the surgeon is in the range of 42 anatomic syntax score if you only talk about that, you know. And don't forget that in the registry of, and we are publishing that very soon, in the registry there were 1,000 patients. So 1,000 patients that up front as an interventional cardiologist said, I cannot do it. Yeah? And if you look at the predicted mortality, if we had treated this patient with PCI, it's terrible. So, I mean, we have to be sober and modest. We make progress all the time, but we are not yet there in terms of three-vessel disease.
So the big question, Patrick, is the impact of the strategy or the technique used in bifurcation for long-term outcomes. So do you have data that you can share?
Oh yeah, that I was expecting that question. So I give 3 slides to the people at the back, which is the 2-stent technique versus the 1-stent technique. So basically, as you could see, there was 699 bifurcated lesions were stented, and you have basically 1/4, which was at that time a 2-stent technique, and you see there's still the V stenting there, the crush, the culotte, etc. And then 3/4 was provisional T stenting, 73%. The next slide show, I think you have confounding factors, that's clear, but for me what is amazing is that up to 5 years, the 2-stent technique and the 1-stent technique are okay. There are no difference, and I was very surprised to see that after 5 years, you start to see this difference, which is not in MACE, which is in all-cause mortality. And of course, as I told you, we have adjusted for many, many factors. It's a complex statistic analysis. I don't know how to make the interpretation of that. Is that something which is more heterogenic because we have seen the story of Kassab and other people. So I think maybe there's a last slide. Let's see if there is something more there. Yeah. This is basically the 1-stent technique versus the 2-stent technique 10 years ago. I have to admit that. So death and stroke, as you could see, 23.7% versus 18.7%. Revascularization at 5 years, 33.3% for the 2-stent technique, 23.7% for the single. As I said, death at 5 years was very similar, 15 and 13.4, hazard ratio of 113. So we were reassured at that time. But in the last 5 years and death at 10 years, the difference came 33.3 versus 25.9. And you cannot dispute, I mean, all-cause death is unbiased. I mean, it's not adjudicated.
Is somebody has an idea what the cause of this was? We observed that, you remember, Patrick, with Nordic 1 and BBC 1, very old trials showing absolutely no difference, a single stent versus double stenting, but at 10 years, a difference in mortality in favor of single stenting. So, and this was randomized. So, what can be so it means that this is probably related to the procedure, but by which mechanism? That's the problem.
I think what we are going to see probably is a combination of stenting and drug-coating balloon. We have seen this morning a beautiful result of drug-coating balloon. Drug-coating balloon with sirolimus. There are currently 4 companies who do that. That's one point. So we will put probably less stent in the simple bifurcation. That's point number 1. Point number 2, what is extraordinary in the syntax trial, that the patient who receive optimal medical treatment, you know, the 4 components, they keep diverging from the people who did not receive. That's phenomenal. So when you see all the new drugs that we get, you know, the PCSK9, and so you will say it's expensive and this and that, but you know that the price is going to go down. MRI, COVID has helped from that point of view. We have now the MRI inclisiran, and so I think that combination of drug-coating balloon, stent, and new medication may clearly change the profile of what we're going to see in the future.
Thank you very much, Patrick. We are running very late, so we have to move to the next session now. Thank you very much. I think we'll have time to discuss about that. I'm sure that Nordic showed that 8 years ago, and it was a surprise. But now for me, it's a confirmation that 2 stent techniques at long term has an impact on mortality. So 2 studies showing that.